Welcome to the Allergy and Asthma Network's 2016 webinar series titled Advances in Allergy and Asthma. I'm Sally Schessler, the network's Director of Education. It is my pleasure to welcome you today to this month's offering in this year's webinar series. We will be inviting nationally respected speakers to join us each month to talk about issues that are important to you. Please plan to join us each month. For our April webinar, it is my pleasure to welcome Dr. Chitra Dinakar. Dr. Dinakar is Professor of Pediatrics at the University of Missouri, Kansas City, and Director of Fair Center for Excellence at Children's Mercy, Division of Allergy Immunology at Children's Mercy Hospital. She completed her fellowship in allergy immunology at the Cleveland Clinic Foundation, Ohio, and since then has been at Children's Mercy. Dr. Dinakar's passion and expertise include pediatric asthma, food allergic disorders, atopic and immunological disorders, and healthcare quality and outcomes. She is the principal investigator at the Children's Mercy Food Allergy Center, one of 22 members of the Food Allergy Research and Education Clinical Trials Network and Centers of Excellence. She serves on the editorial boards of 4 allergy immunology journals and on Missouri Medicine. She chaired the Joint Task Force Practice Parameter Work Group on Yellow Zone Management of Asthma Exacerbations. She has served on review panels for grant funding programs such as the National Institutes of Health and has been a member of the UMKC Pediatric Institutional Review Board. She has been involved in more than 50 investigator-initiated, NIH-sponsored, and industry-sponsored clinical trials and has over 45 peer-reviewed publications and 2 book chapters. She is an invited speaker at national and international allergy conferences and mentors junior faculty, AI fellows, residents, and medical trainees. Dr. Dinakar has served in leadership capacities at the National Allergy Immunology Organizations. She is a member of the Board of Directors of the American Board of Allergy and Immunology. She was on the Board of Regents for the American College of Allergy, Asthma, and Immunology and Chair of Healthcare Delivery and Quality Interest Section of the American Academy of Allergy, Asthma, and Immunology. She is also on the Executive Committee of the Section of Allergy Immunology in the American Academy of Pediatrics and is an elected member of the prestigious American Pediatric Societies. She is a former president of the Greater Kansas City Allergy Society and a former board member of the Swanee Mission Education Foundation. She is a board member of the Food Equality Initiative and Food Allergy Support Group of Greater Kansas City. Dr. Dinakar's honors include the Women in Allergy Award by the American College of Allergy, Asthma, and Immunology in 2015, a Celis Teacher of the Year Award by the International Academy of Science, the Award of Excellence by the American Association of Allergists and Immunologists of Indian Origin, the Golden Apple Mercy Mentor Award by Children's Mercy Hospital, and she's Honorary Kentucky Colonel, awarded by the Governor of Kentucky. She is listed on the Consumer Research Council's Guide to American Top Pediatricians, Best Doctors in America, Kansas City Magazine's Super Docs, and 435 Magazine's Best Doctors. Dr. Dinakar, we are so pleased that you're here with us today.
Thank you, Sally. That was such a kind introduction, and now I know who to go to if I want a good recommendation letter. Thank you so much.
Anytime.
I'm truly honored to be here and really thank the Allergy and Asthma Network for inviting me to do this talk. As you will probably learn through the talk, helping patients take care of their asthma is very, very important to me, and I really would like to disseminate information that will help us better manage asthma. So with that, I'd like to talk about the yellow zone strategies and home management of asthma. These are my disclosures. None of them are really related to our talk, but I do want you to know that I will be discussing unapproved and investigative use, and I will point it out as I go through the presentation. So the main objectives of the talk are really looking at a patient with asthma and thinking about how do they recognize when they're starting to lose control. And as many of you know, we like to look at asthma control using the Asthma Action Plan with the green, yellow, and red zone concept, which I'll explain a little bit. And loss of control, we would look at in the yellow zone. And what strategies can the patient or the individual do to regain control at the home in the mall, outside a medical setting, and how can these instructions be incorporated into a zone-based asthma action plan? I'd like to go through these aspects with you all today. First, I'd like to introduce you to a document you may be very, very familiar with, a very elegant and well-written document called the NHLBI Asthma Guidelines 2007, also called the EPR3 or the Expert Panel Report 3. This document was very innovative in that it moved ahead from the classical definition of asthma severity, which we used in the past to help determine how we treat asthma. The document outlined that asthma severity referred to how bad the disease was and was a sort of clinical guide to help us know what medication to start the patient on. Asthma control, which was a new concept introduced in the 2007 guidelines, referred to how well are we doing with managing the symptoms. So once you start therapy, after therapy is initiated, can we help the patient lead a better life? And that is what we call control. Responsiveness is how easy is it to help the patient reach control once we prescribe the therapy, and what do we need to do during the course of management, stepping up and stepping down to help them achieve control. So these concepts are fundamental to our treatment of asthma, and we need to keep that in mind. I'd like to focus on the control aspect to help manage the patient's asthma on a daily basis. So what are the components of control? The guidelines very nicely laid out two main blocks that we look at. One is impairment domain and one is a risk domain. So impairment domain, as you can see, refers to mainly what you do on a daily basis. What are your symptoms? Does a patient wake up at night? Is there interference with normal activity? How often does the individual use short-acting beta agonists for symptom control? What's the lung function like? What's the quality of life and control? So these are the domains that are used to determine if a patient is doing well, what we call well controlled, where you kind of look at the rules of two, less than 2 days a week, less than twice a month, less than symptoms and nighttime awakenings, less than 2 episodes per year requiring steroids as being well controlled. Not well controlled is when it's a little bit more than that, and very poor control if it's very frequent, occurring multiple times in the day, multiple times in the week, and multiple hospitalizations. Risk refers to more a long-term kind of strategy, looks at the exacerbations, looks at the lung function, is it being maintained, is the person growing like they should be, or are the lungs dropping in their function, and more than that, is there any problem with the medications? Are they having side effects? So that's the concept of control that the guidelines very nicely laid out, and they also went a step further by giving you the different steps of asthma management, starting from short-acting beta agonist use for intermittent, going on to starting inhaled steroids or alternatives for mild persistent, stepping it up for moderate persistent, maybe adding combination products, and then really escalating the therapy as they go on to severe asthma. All this, however, I would consider the green zone part of the asthma action plan. As you all probably do every day, you give your patients an asthma action plan so that they can look at the different strategies and implement them in their daily lives. It is important to empower a patient, an individual with asthma, to recognize the different zones they're in and to step up or step down depending on the degree of control. So the strategies outlined in the 2007 NHLBI guidelines really pertain to the green zone. How do we maintain long-term control of asthma, which is very, very important and probably the most important aspect of the asthma action plan. But the green zone, as we know, really is an allusion to the traffic lights, with green being good, asthma's going well, keep going, and yellow being slow down or caution, and red being danger. So let's talk about asthma control. There was a very important study done in 2004 by Bateman and his group called the GOAL study, or the Gaining Optimal Asthma Control. This study looked at, in a research setting, if you give a patient all the options they have and treat them well and really focus on their control, how much control can you reach? Interestingly, the study showed that only 41% of the patients gained total control, and 71% of them had well-controlled asthma. Now, if you're an optimist, you can say, well, 71% had good control of their asthma, and only 29% had full control. But the point is that asthma control varies over time. As you can see from this slide showing the asthma utilization data at my hospital, you can clearly see that asthma control is not a straight line. It goes up and down depending on different triggers. As you can see, each year we have the classic pollen season trigger with the tree pollen causing a spike in the asthma. It calms down during the summer when it's really hot and all the pollen dies, and then it peaks again during the fall with the start of the ragweed and then the winter season. So clearly, asthma is not something that is stable on a daily basis. It has fluctuations. So if you are an individual with asthma and you have an exacerbation, you're in the house, you're playing, you're in your office and someone is using perfume, you're in the park, you're in the mall, and you have an exacerbation, what should you do? And how can the family help you? What should they be doing? So that is the question we wanted to explore in our practice parameter that I'll be sharing with you. And Partridge and his group actually studied the same question. They asked about 3,000 patients in 11 countries with asthma the question, what do you do when you have an asthma exacerbation? Do you think you can pick it up? Do you feel confident in being able to recognize when you have an asthma exacerbation? And what do you do when you have it? Interestingly, in their study, the majority of patients, we're talking about 88% of patients, stated that they dislike the uncertainty associated with asthma exacerbations, which is no brainer. People don't like having asthma exacerbations, but 88% of them felt confident about self-managing the asthma and intervening early by increasing their medication. So that's really good. Patients feel that they can take care of the asthma. And as a provider, we need to help them continue to feel that way and provide strategies that will help them. When these patients were asked, what do you typically do when you have an asthma exacerbation? They responded saying they typically start using the short-acting beta agonist. They go up in the dose, maybe up to 4 times the dose, and then they add inhaled steroids or whatever the controller medication they've been given. Even though only 29% of the patients were told, use your controller medication when you have an exacerbation, about 52% of them used it anyway, which means that patients think for themselves that, using a controller medication when I'm having more symptoms makes sense. Now, we study the value of an asthma action plan at our center and gave out surveys to our patients to see whether they liked the asthma action plan and what they thought about it. And interestingly, 9 out of 10 caretakers with an asthma action plan reported that it had value in managing exacerbations. So really, there is great value in forming a partnership between the patient and the provider and coming up with strategies to empower them to come up with the asthma action plan. So I'm really going to talk about the yellow zone of the asthma action plan, where the asthma starts getting worse and we need to do something. And why do we need to do something? We need to do that to prevent the red zone, which is a danger zone, where the asthma has become so bad that they require treatment. The treatment could be calling the doctor. The treatment could be going to the ER. The treatment could be requiring steroids. It's treatment that requires medical intervention, and we would prefer that we give them a strategy that helps them treat themselves at home before they have to go to the doctor. So this gave birth to the practice parameter on asthma, where a group of individuals from the 2 organizations, the American College of Allergy, the American Academy of Allergy, and also by the Joint College that's called the Joint Task Force, looked at the different strategies that were possible to take care of patients in the yellow zone and reviewed the evidence. And this practice parameter was also endorsed by the American Academy of Pediatrics and was shown in this article. So the first step in looking at the data was to go back to what the NHLBI 2007 guidelines had recommended regarding yellow zone strategy. Now, that document at that time recommended that when a patient started having symptoms, increased use of the short-acting beta agonist, such as albuterol, that's commonly used here, 2 to 6 puffs every 3 to 4 hours for 24 to 48 hours. So use this strategy, which is more like a rescue or reliever strategy, and if control is not regained, then they may need oral or systemic steroids. That sounded like a good idea, but if you look at it closely, there are some gaps in the recommendations. What are the gaps? Well, really, it means a patient goes from the yellow zone, the patient goes from the green zone to the red zone directly. So they're taking the daily control medication, they use more rescue medication, and then they end up on steroids. So there really isn't a yellow zone. And we just heard from the Partridge study that patients spontaneously step up the medications. So why not we help them step it up? Oral steroids do work, there's no question about that, when a patient is really bad and they're in the red zone. But in some situations, such as viral triggered exacerbations, there are recent studies suggesting that they may not work that well. More than that is the danger of prescribing something that might cause harm. As you know, the dictum is do no harm. So repeated oral steroid bursts and safety is definitely a concern, especially in the kind of patients I see. I see a lot of pediatric patients, and therefore I do worry that the steroids I give now may cause long-term concerns. I do want them to live long, happy lives and not have side effects of the medications I'm giving them. Therefore, the need to come up with interventions that don't have great side effects but have a good benefit-risk ratio. So the next question is, can early intervention actually prevent asthma exacerbations? And if you draw a graph with the asthma symptoms and days after start of a cold, the point is that when they start, they're in the green zone, they get a cold, they start losing control. Instead of going to the red zone, can we get them back, or the yellow zone, can we get them back to the green zone? So the best way to answer that question is to actually look at the chronobiology of asthma. And this was done in a few studies. An elegant one is a Tattersfield study, which looked at peak flow in the morning, peak flow in the evening, asthma score at night, asthma score in the day, and try to look at exacerbations of asthma. As you can see, these graphs are so beautifully illustrative of the fact that there is clear mirroring of loss of lung function with worsening of asthma scores, whether it's daytime or nighttime. And what you can see is that somewhere between day -10 to day +10 or -14 to +40, you can see around that time, so probably 7 days before and 7 days after, there is a gradual decline and then a steep decline, whether you're talking about symptom scores at night or day or peak flow. So what does that tell us? Yes, there is a window where patients start to dip in their lung function and increase in their symptoms, that we may be able to intervene. And that is the concept of the yellow zone, trying to quickly get the zone of acute loss of asthma control and correct it so that they don't end up in the red zone. The triggers could be allergic, it could be infectious, it could be non-allergic, it could be irritant, it doesn't matter. We need to promptly recognize their symptoms and signs and treat them, get them back into this good part of the asthma zones and not go into the red zone. So what is a yellow zone? A transition zone of acute or short-term loss of asthma control, which happens in the home. We're not talking about stuff that we do when the patient comes to see us. That's not part of the recommendations I'm discussing. I'm discussing stuff that patients can be given to empower themselves at home. The goal is to regain control and prevent deterioration in the red zone, which means oral steroids or utilization. So what we did, we looked at different studies that had actually looked at yellow zone studies where they took patients who were in the green zone and then got sick and told them what to do. And then we looked at large studies which just looked at asthma natural history and their courses with different interventions. And we used therefore direct data and indirect data to come up with some of the criteria, because it's really hard to do yellow zone studies because you'll have to follow patients for a long time to see if they get sick and what happens when they get sick. So the criteria we came up with were if there's an increase in symptoms more than 2 times a day over baseline, because some patients require inhalers 2 or 3 times a day, even on a normal basis. So you can't give a number, it's just a number greater than what they normally do. An increase in the use of reliever medications, or if symptoms do not improve or come back less than 4 hours after treatment. The presence or increase in nocturnal symptoms, peak flow decline in those patients who do use peak flows. Now, it's not a very large group of people who use peak flows, but in them, if they do have their normal range, if there's a decline of more than 15% or less than 80% of Christmas dust, then that might be a criteria, or onset of a viral respiratory infection. Now, you may notice that we said strong recommendation, and a strong recommendation means that the benefits clearly outweigh the risks, and a provider might really want to use this recommendation in their daily practice. B, evidence means that there are randomized controlled trials or large trials, but not very robust. That grade A evidence means it was really a very robust randomized controlled trial. An example of a study we looked at is the Fitzgerald study. As you can see clearly, during the time of the exacerbation, you can see an increase in the nocturnal symptoms, which is why we use nighttime symptoms as a criteria. Though when we reviewed the studies, it appears that this seems to work better in adults than kids, because kids sometimes have nighttime symptoms due to colds and other reasons, and which may be a little confusing. Short-acting beta agonist use that was mentioned as the primary yellow zone treatment in the NHLBI guidelines was evaluated by us, and it showed that scheduled use really does not prevent progression. They would tell somebody to take albuterol on a regular basis when they, regardless of their symptoms, did not seem to prevent an exacerbation. And we therefore recommend that patients use the inhaled short-acting beta agonist at a dose of 2 to 4 puffs via the meter dose inhaler or nebulizer treatment every 4 to 6 hours as needed, in addition to the escalated yellow zone treatment. And if the use exceeds 12 puffs per day, advise patients to contact their provider for the guidance. So we set a cap on how many puffs we thought was safe enough for them to take at home, and this might exclude the triage zone where you take 2 puffs back to back. So if they really reached about 12 puffs per day, they probably were taking too many puffs and needed to see a provider, and this was called a recommendation with C evidence. So what are the triage steps? So in our action plan that we give our patients, we actually have this written down where we tell them step up therapy if any of the following occur, and these are the yellow zone criteria. And then if they're having these symptoms, we tell them to use 2 to 4 puffs with a quick reliever or 1 nebulized quick reliever treatment if that's what they have. If they are better, great. If not, repeat it in 20 minutes. If you're not better, one more time, 20 minutes. 3 times you've used it and you're not better, then you are in the red zone and you need to initiate your red zone plan, which might be call the doctor, start steroids, go to the ER. It just depends on what you've written out for them. If they do improve, then they're in yellow zone, because the fact that they needed the albuterol treatment 3 times in an hour means that the asthma is not well controlled and they need to go into the yellow zone. The next question that often comes up is how long should the yellow zone be? Well, as I showed you in the graph, and this is another study, this is the PACT study, so you can see a very similar graph of the chronobiology of asthma telling you that there is this window, about a 2-week window, so from -7 to +7 sort of, where it starts dipping and then it takes that much time to come back to baseline. So while there's a variability in literature, we think that 2 weeks would be a reasonable time to cover both the symptoms and the lung function, because remember, patients feel better faster than the lung function. So some of them will stop their treatment after 2-3 days thinking, I feel better, I can stop it now, but peak flows take much longer to come back and we don't want to relapse. So what are the step-up approaches in asthma? This was very elegantly looked at by Dr. Lemansky and his group from Wisconsin, and they wrote this really nice article which classified step-up approaches as step-up long-term, where you're increasing therapy over weeks, and that is really the green zone part of the asthma plan, so I'm not going to talk about that. The step-up short-term is when you have a brief loss of control. Let's say you got a cold. Let's say you went to grandma's house and she had a cat, and you're allergic to the cat, and you had symptoms. That would be what we call short-term, where you quickly step up your treatment and in a few days you're better. But it takes about 3 to 10 days to get better. The intermittent step-up is, let's say you're out there in the soccer field and you have symptoms and you treat yourself. You come back that evening and you have symptoms and you need another treatment. That will be more step-up intermittent. Regardless of what you need to step up, the key concept emphasized is that each yellow zone episode may require a different amount of supplemental anti-inflammatory medication, namely inhaled steroids, to prevent progression. And that's because I just described to you how you have a short-term, intermittent or short-term, longer time. So you may need a different amount of the anti-inflammatory steroid depending on how bad your exacerbation is. And we have identified the inhaled corticosteroid as the main intervention that would make a difference in our setup. There are other interventions, though, that are laid out. One is the scheduled dosing, where you can increase the inhaled steroids over 24 hours. You can either give 4 times the dose twice a day or 4 times a day. There is a concept called dynamic dosing that I'll introduce to you, where you piggyback the inhaled steroid every time you use a reliever. So every time you use a short-acting beta agonist, you add an inhaled steroid dose. That strategy might work more for something like the soccer game strategy I told you, whereas a scheduled dosing might be better for when you have a cold and you start getting sick. The adjustable maintenance dosing I'm going to introduce to you, but may not be applicable to our country at this time, and it's definitely off-label use, and I'm letting you know that. And I'll tell you why it's not applicable to our country. It's more because of the FDA regulations against LABA use. However, this has been used in other countries, and therefore I will show you the data on that. So let's talk about scheduled dosing, which is increasing the dose of inhaled steroid. The recommendation by the practice parameter that we're calling an option and B evidence is that those who are on daily inhaled steroid dose, which could be low or moderate, so we're talking about a green zone plan where you're taking daily inhaled steroid, these patients can increase the total dose up to 4 times or greater for managing loss of asthma control. The way you do it could be an increase in frequency, which means you tell them to do it 4 times a day, or increase in puffs, where you quadruple it and say continue the twice a day. Doubling doses, which we used to do prior to the 2007 NHLBI guidelines, is no longer recommended because the studies did not show that it made a difference in the recent studies that we looked at. Though we will admit those studies had weaknesses in design, in that the intervention was started about 48 to 72 hours after the symptoms started. It was not studied on patients who were not on any medication, and we use that strategy in our hospital a lot, and patients like it, and therefore in those patients who like it, we leave it on, but evidence-wise, it's not recommended at this time. What has been shown to work is quadrupling. For example, there is a study quoted even in the 2007 guidelines called the Faresi study, where they took patients who were on quite a high dose of budesonide, 800 micrograms twice a day. After they were controlled, they stepped them down to one of the 3 groups. Group 1 was on high-dose budesonide twice a day with placebo. Group 2 was low-dose budesonide plus quadrupling dose 4 times a day, and Group 3 was low-dose twice a day plus placebo. They looked at asthma exacerbations as the primary outcome, defined by a fall in peak flow, calculated during the last 2-week pre-treatment period on at least 2 days. So they used the outcome of an asthma exacerbation to see which strategy was good. Now, if you look at this, the patients in Group 2 who had a quadrupling of the ICS at the onset of exacerbation had significantly better outcomes. So you can see here that Group 1 and Group 2, and going back here, were the high-dose daily budesonide or the low-dose budesonide with quadrupling were very similar in being able to prevent exacerbations. You can see 83% or 82% did not have exacerbations, whereas 68% of those who were on the low-dose budesonide plus placebo did have exacerbations. And you can see similarly, the only 11% had 1, and only about 4 or 5% had more than 2 exacerbations. So they did very well to prevent the number of exacerbations, and not only that, they also did very well in improving the number of days without exacerbations. That was an older study. A more recent study by Born in 2009 looked at a randomized controlled trial, and this included children more than 16 years who were on moderate to high dose of beclomethasone, and looked at a large number of subjects and had similar intervention criteria of asthma deterioration, upper respiratory tract infection, peak flow decrease, with either 15% on 2 days or 30% on day 1. Similarly, they looked at usual asthma treatment compared to quadrupled ICS dose. And the primary outcome was the exacerbations requiring steroids. Now, in their main group, they found a trend towards significance in the risk ratio, but it wasn't robust. But when they looked at patients who were adherent to the study protocol, you can see 21% active versus 50%. They had a significant risk reduction ratio of 0.43. In other words, exacerbations were significantly reduced by more than 50% relative to the relative risk reduction of 57%. Of course, this only worked in the patients who actually took their study medication. If you didn't take it, it's not going to work. therefore, this study was not graded as an evidence A study, even though it actually showed that it worked. So how about preschoolers, which is always a very difficult group because they are not yet fully declared to be asthma. They may be wheezing more like bronchiolitis type of wheezing. What can we do in those patients? So different options were studied in this group, and let me summarize it by saying for children less than 6 years of age with recurrent wheezing and risk factors to subsequent asthma, what we call a positive modified asthma predictive index, we suggest considering initiating high-dose ICS or oral montelukast to reduce the intensity of symptoms. Unfortunately, it did not prevent the need for oral steroids. So it seems like in that group, no matter what you do, they still end up, following the natural course of their exacerbation. But if improvement in their symptoms is a consideration, then starting inhaled steroids or montelukast might work. We call that an option with B evidence. An example of a study was a carrier who looked at a high-dose budesonide, we're talking 1 milligram twice a day, compared to montelukast, compared to conventional therapy. And you can clearly see that compared to conventional therapy, there was an improvement in symptoms. But I want to remind you, it did not change the course of the need for oral steroids, which was a little bit of a bummer. The next strategy I'd like to bring up is the dynamic dosing, which is a very interesting concept where rather than the traditional schedules type of approach we're used to and have been following regarding asthma management, we are now talking about use ICS along with the reliever, which is concomitant dose of ICS with reliever use. So this is the symptom-driven use of controller with reliever therapy known as dynamic dosing. And what this means is patients with asthma of mild severity receive greater or lesser amounts of inhaled steroid in proportion to the asthma control. And how they achieve this is by piggybacking the inhaler containing the inhaled steroid to the short-acting beta agonist inhaler. Now, this would be really terrific if we had a single inhaler which contained a short-acting beta agonist and an inhaled steroid. There are some countries that have it, especially in South America, but we don't have it here. So unfortunately, it requires the use of 2 separate inhalers in our country. But the concept that I'm going to show you that has been studied is that this strategy really helps our patients. So this is called symptom-based ICS use, and we looked at the evidence here, called it an option, and B evidence. For patients with mild to moderate asthma, consider recommending symptom-driven use of inhaled steroids with concomitant inhaled beta agonist use. Now, there were some researchers who studied this for PAPI, but PAPI in 2007, and I told you in this country, in Argentina, they have a single use of beclomethasone and albuterol. So they looked at the use of as-needed combination therapy, daily beclomethasone, regular combination, and as-needed albuterol. And found that as-needed inhaled steroid short-acting beta agonist in adults, which means whenever you have symptoms, then you take the inhaler. If you don't have the symptoms, you don't have to take it. Surprisingly, they found it was equivalent to daily inhaled steroid use with regards to time to asthma exacerbations. Now, this is not for every patient. This study looked at the mild persistent asthmatics who are getting stepped off their medication to see, do they continue to need to be on daily inhaled steroids, or can we step them off? And the good news is that what patients tend to do for their very mild asthma, which is use medication only when they're symptomatic, seems to work. This was studied in children by Fernando Martinez and published in The Lancet in 2011. Same concept, comparing 4 groups. Combined ICS group, which is really beclomethasone for both daily therapy and rescue with albuterol, daily ICS, rescue ICS, which is where you're on nothing on a daily basis, but take beclomethasone for rescue, and then the placebo group. And you can find similar exciting results in that for the very, very mild asthmatics, daily ICS use, combined ICS use, and rescue ICS use all had similar results. Of course, markedly different from placebo. More importantly, you can see that the rescue ICS and placebo had minimal effects on growth, on linear growth, which is very important for our pediatric patients. And the difference was about 1.1 centimeter. And there was about a 15 to 25% less steroid use in the rescue ICS, which is an obvious thing because they were obviously using less medication. But the good news is we are at least trying to minimize the dose and the probable side effect that they may be getting, yet maintaining good asthma control. But again, I want to stress that is used only for the very mild asthmatics who are doing well relatively. It did not work for the moderate persistent asthmatics. It was tried there and it did not work. The next concept is adjustable maintenance dosing, where the patient uses ICS with a quick onset, long-acting, what we call LABA, in a single inhaler as both maintenance and reliever. So the medications we're using really contain formoterol, which is the agent, one of the agents that has an acute onset response like an albuterol, but lasts for about 12 hours. So the advantage of this is you have an anti-inflammatory therapy on board with the inhaled ICS, but you also have symptom relief with the long-acting beta agonist, and a single inhaler, which would be great for our patients, because what can be better than having just one inhaler that you use on a daily basis and then use more of it when you have symptoms? So it's really a win-win situation with the adherence valve. Other word terms you might see with this are called maintenance and reliever use, and single inhaler maintenance and reliever therapy, or SMART. There are many, many studies that show that this strategy works. And in fact, it has become standard of care in many countries in Europe and Canada. So if I can focus your attention to the red bar, which is the combination of budesonide and formoterol, maintenance and reliever, which is a concept we're studying. And you can compare this to any other strategy. So the first strategy is just an inhaled steroid with short-acting beta agonist. Or if you compare it with the combination product with a short-acting beta agonist, or you compare it with a combination product with a long-acting beta agonist, or you compare it with salmeterol, fluticasone, with a short-acting beta agonist. Regardless, you can see that this dynamic dosing or adjustable maintenance and reliever therapy had really significant effects in terms of exacerbations. So it was shown to be superior. Unfortunately, in the US, there is no FDA approval for adjustable maintenance therapy, and therefore this is off-label. Turbuhaler device used in these studies that I just showed you is not available for use in the USA. As you may know, we have the meter dose device here, and therefore it is really not necessarily comparable to the Turbuhaler device. Maybe there are differences, and we need to study the devices we have here. The studies used up to 3 times the FDA-approved dose, so they were much higher than approved. And as we all know, there's an FDA box warning regarding the long-acting beta agonist component. Other concerns are that if you use a symptom-driven approach, maybe in patients who are poor perceivers of their dyspnea, they may just use more of the medication and not realize that they're not having a problem. Or if you're overusing your inhaler during periods, would you exceed a certain safety dose, and would it be harmful to you? So those are, of course, legitimate concerns that might limit the strategy in the US. Cochrane reviewed the safety of this strategy. There were over 20 randomized controlled trials with 10,000 adults and 7 randomized controlled trials with close to 3,000 children, and they found that there were significantly fewer asthma-related adverse events in those taking regular combination compared to the ICS alone, and no significant difference in the adverse events. But in children, they found that there just weren't enough number of data and events to draw meaningful conclusions. And to really get a number on this, there were 7 deaths of adults in over 13,000 patients with asthma, and only 1 were related to this thing. Another Cochrane review demonstrated that this is a more recent one, that this AMD approach can reduce exacerbations requiring oral steroids against current best practice strategies and against a fixed higher dose. But they found more discontinuations due to adverse events compared to current best practice, but no significant differences in the actual adverse events. But the authors here too advise against use of this approach in children and adolescents less than 18 years, just because there was limited research evidence in this age group, not because they thought it was a safety concern, but just because they did not have enough numbers to make this a robust recommendation. So that is the data that we reviewed in the practice parameter that got published in that the AAP endorsed. But the question is, what do other countries do? What do the other guidelines advocate? And I'll give you an example. I told you in Europe and Canada, they do use the SMART strategy, but let's look at the GINA strategy, which is a global initiative of asthma, which is a strategy that is agreed on by many countries, and I'm going to show you the most recent recommendations that was written recently in 2015. States that there are revised recommendations of the written asthma action plans. Based on a review of all relevant evidence, GINA now recommends that an early increase in ICS dose should be advised in action plans, either by prescribing the ICS formoterol maintenance and reliever regimen, that's the adjustable maintenance dosing that I showed you, or by a short-term increase in the dose of maintenance ICS formoterol, or by adding an extra ICS inhaler as the different strategies. So pretty much talking about the same strategies that were mentioned in the yellow zone practice parameter. Then just to recapitulate, when the NHLBI guidelines came out with in 2007 with the strategies to say use more short-acting beta agonists for the yellow zone, that's what the GINA guidelines had also said. So this is a recent change in update in their guidelines, and maybe this will reflect on ours once we review our guidelines. So this is a table box 4.2 that I'd like you to look at your leisure that is really telling you what the global initiative of asthma people are thinking in terms of what to do, and I will break it down. So the top part of the box talks about self-management of worsening asthma, saying we need to monitor symptoms, have a written action plan, regular medical review, and all patients should, when they're getting, having exacerbations which are early or mild, increase in reliever, early increase in controller, and review response, what I'm calling the yellow zone of our plan. And of course, if they get worse, then it's the red zone that we're used to. So what other strategies they're recommending? They are recommending short-acting beta agonist, increase frequency. They call that great evidence. And there are other strategies that they're recommending that are not applicable, as I said, right now to us, but they are talking about maintenance ICS with SABA as reliever that we can use here, which is at least double the ICS. Consider increasing ICS to high dose, maximum 2,000 microgram per day, beclomethasone equivalent, which is grade B, which is a recommendation that might be feasible here. So let's talk about, now that I've shown you the guidelines, how, or the recommendations of the practice parameters, how do we actually implement them? What does this mean for our patients? How do we prescribe it? And I'm just going to give you an example of what we mean by quadrupling, because sometimes the math gets confusing. And I'm going to use brand names because it may be easier for you to relate to it. So let's say a patient is on Flovent 44 micrograms, 2 puffs twice a day. Then what we mean by quadrupling, there are two strategies. You could either say Flovent 44 micrograms, 8 puffs twice a day, so 2 times 4 would be 8. You could say Flovent 220 micrograms, 2 puffs twice a day, if you wanted to give them a different strength, but not that much increase in the number of puffs. Or you could use Flovent 110, 4 puffs twice a day. We can talk a little bit later about which strategies we might want to use and why, but they're just different ways of doing it. And the other question I often get, what would you do if you're in a combination product? Can you go up on the combination product? What we recommend would be just to add the pure inhaled steroid to the combination product, because remember, we do not want to go up on the LABA component of it. We do not want to exceed any safety doses. The last question I bring up is, what about oral steroids? And this has been asked to me, do you, in contrast to your emphasis on trying to avoid too many courses of oral steroids, ever provide a script for 4 or 5 days of an oral steroid to use for a defined exacerbation with no refill, such as those who have been in the ER for an asthma exacerbation? A doctor had actually emailed this question, and the answer is yes, because we always manage the red zone with oral or systemic steroids. Now, whether in your practice you'd like them to come to your office before you give it to them, or you prescribe them a dose to keep at home to start, doesn't matter. We do recommend that. That's not what we're talking about. We're talking about before we get to this stage, what are our options that we can use. So to summarize what we talked about, I'd like to just give you the information in an encapsulated form. The first recommendation is to prescribe asthma action plans with instructions on daily medication use, if any, using the EPR3 guidelines as the framework for green zone. So again, I want to emphasize that though this entire talk was in yellow zone, the green zone is really the most important part of the asthma action plan. And we do want patients' asthma to be well characterized. If it's persistent asthma, they need control medications, and we do need to do that. However, if they are doing that and they have loss of control, We do want to empower the patients to recognize impending asthma exacerbations that we call yellow zone and provide instructions on step-up therapy. We do want to prescribe instructions on using repetitive doses of short-acting beta agonists. For instance, you can use it 2 to 4 puffs 3 times back to back. Try that strategy. If you're better, then you're good. If you need more of those doses, then you're in the yellow zone, what we call the triage zone. Now, what step-up strategy could they use? Consider prescribing quadrupling or higher doses of inhaled steroids as step-up therapy option. Alternative step-up therapy options to consider. Again, remember, these asthma action plans are flexible. They're a partnership between you and your patient. So you want to do the option that the patient prefers and that you think is appropriate for them. So it's not that one size fits all. It's that we have to prescribe the plan that works for the patient. And it's not that the same dress will fit them every time. You might use one strategy one time, and if it didn't work, then just try the other strategy. So alternative strategies could be to piggyback ICS to symptom-based bronchodilator use. Every time they requires the short-acting beta agonist, you would add an inhaled steroid and see if that works. Again, that might work only for the very mild patients. As I just said, tailor the strategy to the patient for their preference and response. And if it didn't work, the first strategy didn't work, feel free to switch to another one. Still, the concern about yellow zone, I've heard a lot, is the false start concern. Okay, what if the patient started an inhaled steroid, when they didn't need it? Is that a problem? Yeah, we certainly don't want patients to be starting medications they don't need, but think of the other side. If they had a late start and they ended up on steroids, they ended up in the hospital, they ended up in the emergency department, the amount of medication or the disruption to their life is much greater than the false start, and therefore our consensus is a false start is preferred over the late start. Therefore, prompt recognition and initiation is great. Let them start it. If the child got better in 10 days, in 7 days, okay, step down to green zone, great. But we don't want the child to miss the symptoms for 7 days and then end up in the red zone. Continue the yellow zone strategy for 2 weeks, because if you stop too early, then you might start having a flare-up. I would like to conclude by acknowledging my co-authors in the practice parameter, Dr. Portnoy, Dr. Oppenheimer, Beccaria, Dr. Lee, and Dr. Kirksmar, the members of the practice parameter joint task force who reviewed the document, the American College, the American Academy, and we did consult with Dr. Bussey and Dr. Lemansky, and then Dr. Fox, Zeffler, Rafiq, Rachelevsky, Schatz, Stoloff, and Blaise reviewed our manuscripts and the documents and gave us really great suggestions, and others also wrote in comments, Christine Wagner and Anne Borgmeyer. So that's what I wanted to say. Thank you so much for your attention. I really appreciate the opportunity to share this information with you to help our patients be empowered to take care of asthma exacerbations.
Thank you so much, Dr. Dinakar. That really talks very clearly about what we should be thinking about for our patients or ourselves when we get to the yellow zone. At this point, we do not have any questions written into the chat box. If you have any questions, please use the chat box on your computer. Oh, we do have a few questions. They're popping up now. One person wanted to know what was the age range in this study. I'm not sure which study they're referring to, so that's kind of a hard question for you to answer.
Okay. I can still give a non-specific answer.
Okay.
I would say that any of the studies or any of the strategies we presented did include children, particularly more than 16 years of age. So a lot of the studies I presented did include them. So we are talking older adolescents and then young adults. The PAPI study was on children. The inhaled steroid piggybacking in the mild persistent asthma was in children 12 and over. So we're not talking little children. Now the studies that showed in preschoolers were obviously in little kids. Where you use a 1 milligram budesonide, the Beccaria study that I showed, that was in little kids. So, but do remember only the combination therapy, we made sure to stress not to use that strategy in those 18 or younger.
Okay, thank you. Here's another question. My child's asthma is well controlled at home, but school is a problem. Her peak flow readings are inconsistent, and therefore we have not been able to establish a personal best. Is there another way to access when my child is in the yellow zone or worse?
Excellent question, and I can't tell you how important this is on a daily basis to many parents and their families. We think that peak flow is very helpful, but a lot of our patients are not able to do peak flows. And studies have actually shown that symptom based assessment is comparable to peak flows and is pretty good. So in our action plans, we actually also put symptoms. So I would suggest that this parent also looked at symptoms. Does the child have problems while running in the gym, or whatever situation they described? Are they able to run as well as the other kids? Are they having to stop and short of breath or cough? Are they wheezing? So symptoms could also be used if peak flows are inconsistent. And yes, peak flows are effort dependent, meaning you have to blow well to do a good job. And sometimes if you're not able to blow well, then you can't get a good peak flow. So that might be hard. But looking at symptoms, so if there is a gym teacher or a nurse or someone who could observe the child, and they are trained to look at these symptoms, that might be a good additional information too.
Great, thank you. I think we have time for like 2 more questions. Here's one. If you quadruple the patient's ICS, how do you deal with the insurance company, etc., because they'll run out quickly? We have a lot of issues even getting an extra ICS inhaler for patients with multiple caregivers, including split custody.
I know, and that is actually $1 million question, and something I think is a brilliant question because it's come up a lot. Different ways of getting around it, but I think the best way would obviously be to make this part of NHLBI guidelines, and once it's in the guidelines, and the insurers will follow. What I showed you was more the practice parameter, which is a step before it goes to the guidelines, and I think the NHLBI is going to meet and talk about this aspect. So hopefully there will be some light at the end of the tunnel. But for now, this is what we have done. We have found that if you prescribe 2 separate inhalers, there's a higher chance of it being covered. In other words, let's take fluticasone or Flovent, for instance. If you did Flovent 44 for green zone and did Flovent 220 for the yellow zone, then somehow the insurers don't seem to mind covering it. Don't ask me why, but that seems to be how. The problem, though, is inhaler confusion. We don't want the patient to have too many inhalers that look similar, and that does confuse them, and it's not fair when they're actually flaring up to have different inhalers that are confusing. So we try to label it and put green and yellow if we can. But if the inhalers are different in color, that's pretty easy. Or if the family is, medically trained or something, it's easy, yes. But those are challenges, and you have just hit the nail on the head. Those are some of the challenges with this strategy, yes.
Thank you. Here's another question. I have several students who come to the school health office claiming they need their inhaler. When I listen to them, I often do not hear wheezing, and their breath sounds are clear. Should I go ahead and give them their inhaler?
That's a great question. I'm sure you're also using a history and other and evidence as much as you can to determine if it is asthma or not. I obviously am an allergist, so I have the advantage of having a spirometry that I can do, exhale nitric oxide. But short of that, a peak flow monitoring might help. In last resort, sure, a trial inhaler may be something that's helpful, especially if they can keep a symptom diary and if they will do peak flow monitoring and use that. But it is a challenging situation, and I think trying to assess clinically might be helpful. Before that, just coming back to the other inhaler question too, I wanted to add, now sometimes, since the inhalers cause inhaler confusion, we sometimes just tell patients to increase the same inhaler that they have, which means they run out of it quicker. We also, like I said, tend to do the doubling, because in some of our patients who've been on the doubling strategy, it seems to work. And if it works, we leave them on it, and then they don't run out of it that much. But those are limitations of this strategy, yes.
Well, thank you so much, Dr. Dinakar. There are more questions. I may have to send those to you to be answered, but that's all we have time for today. So thank you all for listening. Please be sure to register and join us for the remaining webinars in our series. The next one is May 26th at 4 p.m. Eastern Standard Time, or Eastern Daylight Time, I guess I should say now. Join us to talk about seasonal allergies, and we'll ask the question, why does every year seem to be the worst year ever for seasonal allergies? Our webinar series helps the Allergy and Asthma Network live out our mission to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. And before we part ways today, please access the Allergy and Asthma Network's website at allergyasthmanetwork.org for valuable information with sections designed for patients and healthcare professionals. Finally, there are 2 great events coming up. Please check our website for information and registration for our Allergy and Asthma Day on Capitol Hill on May 12th. Learn about important initiatives and make a difference by visiting your legislators. And watch for information about our U.S. Anaphylaxis Summits in September. We'll be presenting these in Las Vegas, Nevada, St. Louis, Missouri, and Orlando, Florida. Our sites this year are great for some personal and family vacation time, as well as a great time to address important issues that affect so many of us or those we care for. This is Sally Schessler, Director of Education, and on behalf of the Allergy and Asthma Network, thanks for joining us today.